Raise your hands if you've seen an EKG before. Just kidding, that was a joke. I can't see you. Dr. Eindhoven is the inventor of the EKG. This is a gentleman who decided to fill some tubs with salt water, stick a leg and two arms in the salt water, hook the salt water tubs up to electrodes and see what happened. And lo and behold, he determined that if you hook a pen up to these electrodes and watch the pen wiggle around on the paper, it will coincide with the beat of your heart. Thus spawned the EKG that we know and love today. So what we'll talk about today is sort of very briefly the anatomy of the heart and how that pertains to the electrophysiology of the heart and what is electrophysiology. And then we'll talk about the basics underpinning the interpretation of the EKG and then specific patterns on the EKG such as heart attacks and rhythm problems, and we'll look at some sample EKGs if we have time. This is the heart. Let's see if anyone's able to see my mouse. I assume you're able to see my mouse. So the heart has 4 chambers in the mammal. These are the atria, right and left, and the ventricles, right and left. And the atria receive blood, so the right atrium in particular. The right atrium receives blood from the venous side of the body. So blood returning from the rest of the body gathers in the right atrium and is sucked into the right ventricle, which propels blood into the lungs. And sort of behind this image, if you could see through this stuff up here, you'd see the pulmonary arteries. So blood being shoved with each beat of the heart from the right ventricle into the pulmonary arteries, and then the pulmonary vein gathers that blood that's been newly oxygenated and transmits it through the left atrium here into the left ventricle, and the left ventricle is the big muscular chamber of the heart, and when that squeezes, blood squirts into the aorta and out to the rest of the body. This is what the heart looks like on the outside, and you can see that there are arteries that sort of wind their way around the outside of the heart. And the big ones are the right main artery and the left main artery, coronary arteries that is. And in particular, the left main coronary artery divides into the left anterior descending coronary artery, which provides the bulk of the blood to the left ventricle, and then the left circumflex artery, circumflex meaning it bends around and goes other places. So circumflex circumferentially goes around the back of the heart and provides posterior blood supply. And the right coronary artery gives blood to the right side of the heart. This also happens to be the inferior side of the heart if you're inclined to listen to your docs talk about the patient's inferior MI, things like that. And this is what a normal EKG looks like. So when someone comes up to me in the emergency department and says, "Hey doc, look at this EKG," I'll be looking at 12 leads recording voltage changes on a piece of paper. And from that, I'm supposed to determine whether or not my patient should go directly to the cath lab and incur lots of expense and hopefully be treated for their devastating cardiac illness, or if they can wait in the waiting room for a couple of hours and are boring to me. The leads 1, 2, and 3 are sort of the main leads that Dr. Eindhoven learned about when he performed his experiments on himself. And since that time, further leads have been developed. The augmented leads, AVR, AVL, and AVF, referring to right, left, and down to the foot. And then the precordial leads, or leads arrayed around the chest, which we'll talk about in a moment. But there are 12 of these leads that we pay attention to most commonly. People talk about posterior leads and right-sided leads, and you can perform variations on these leads based on what you're looking for. So the limb leads. The limb leads attach to the limbs and record voltage changes in sort of a vertical orientation or a plane oriented along the limbs, if that makes sense. So lead 1 attaches on the right arm and goes to the left arm and receives signals basically right to left in most cases. So it's as though a camera is stationed on the left hand looking towards the right hand. And if a voltage change across the heart is coming towards the camera, if the voltage is propelled right to left, then the lead will deflect vertically on the vertically upwards on the EKG paper. And if there's a voltage propelled away from the left hand, the lead will deflect negatively or downwards on the paper. And we'll look at what that looks like in a moment. Similarly, you have lead 2 that goes from the right hand to the leg. And lead 3 goes from the left hand to the leg. And from those limb leads, as they're called, you can derive augmented leads. So you can imagine that lead 1 will pay most attention to depolarization across the heart happening in a right to left direction. Lead 3 will happen in sort of a diagonal direction from head to toe and right to left. And lead 3 will also register head to toe and left to right. And you can imagine sort of an XY axis and determine which direction these voltages would take as they these voltage potentials would take as they travel across the heart and down the limbs. And the augmented leads are variations on these directions. The precordial leads are arrayed so that they register voltage changes not along the plane of the limbs, as with the so-called axial leads, but the precordial leads register voltage changes that take place sort of horizontally or through the cross-section of the thoracic cage. So if a lead is seeing a voltage potential coming directly at it from the direction of the back of the heart, say, lead V1 will register an upward deflection on the EKG paper. Similarly, V2, V3, V4. And from all of these leads, we can derive what's happening electrophysiologically in the heart at any given time. And what we see when we look at the graph paper is a series of boxes. So big boxes and then little boxes inside the big boxes, each big box representing a time horizontally in millimeters or milliseconds, each millimeter representing 40 milliseconds. And vertically, this is your voltage potential expressed in millivolts. So how far a lead deflects vertically on the y-axis of the EKG paper gives you a sense of the strength of that signal that the EKG lead is registering. So each small box is 40 milliseconds. Each large box is 0.2 milliseconds. All right. So let's look at the tracing on the EKG that you are likely to see. There are waves represented by letters, and corresponding to the latter half of the alphabet. What happened to waves A, B, and C, we will never know, but it starts with P. The P wave is the wave that is generated by the depolarization of the atrial muscle. So the atria contract and pump blood into the ventricles, and that atrial muscle contracting gives rise to the P wave. And this is a relatively little wave. The reason it's little is because the atrial walls are thin. Not a lot of myocytes contracting to give rise to this wave. And then there's a delay as the electrochemical signal progresses through the muscle of the heart, through specialized fibers that we'll talk about in a moment. And there's a little bit delay, and then the ventricles depolarize and contract, and that gives rise to this very large complex called the QRS complex. Q is any downward component of this deflection. R is the vertical upward component of the deflection. S is the vertical downward component, and then the T wave. And the T wave happens usually after some very minimal delay. Often there's no delay. You go straight from the S wave into the T wave. And then once in a while, if there's some sort of electrolyte disturbance, for instance, you'll get a U wave. But you usually won't see a U wave unless there are interesting circumstances. And then we pay attention to various of these intervals. So the PR interval is the beginning of the P wave and the end, or the beginning of the R wave, or the Q wave. People will talk about the QRS complex even if the Q wave is absent. Oftentimes, the P wave will give rise directly to the R wave, and the Q is silent, as it were, the silent Q. The QRS interval is an important interval that we look at. How long does it take for the voltage to travel through that myocardium to depolarize the ventricles? And then the QT segment is an important segment, and the ST segment is an important segment. And when we're talking about heart attacks in particular, the ST segment is all the rage. And the J point is where the S wave becomes the T wave. And the J point is important to look for when we're talking about things like cardiac ischemia. So once again, P, QRS, T, and P is where the atrial contraction occurs. QRS is your ventricular contraction. T is your ventricular relaxation. And this is where we see the heart repolarize. So what's happening with all of these contractions is that ions are being transmitted from one side of the heart muscle cell membrane to the other, and that results in polarity change, which when it builds up to a sufficient amount in terms of millivolts, that muscle cell will contract. And when they're done contracting, they repolarize, so those ions are transmitted back to their normal position relative to the cardiac myocyte membrane, and they get ready to contract again. The conduction, do we have any questions so far? Any comments from the audience?
I am not
any suggestions?
Not seeing any, but I think it's giving me a little bit of trouble. So.
All right, if you have any questions, we're going to ignore them because of technical reasons.
Them to me. I am responding as fast as I can.
Okay. You can feel free to email Ariel. You can call her at home tonight when you come up with your questions. She'll answer calls at 2 a.m. So let's talk about conduction. Conduction through the heart starts at what we call the sinoatrial node. Sino, because it depolarizes and repolarizes in a sinusoidal fashion. Sinoatrial, because it's located in the atrium. So sinoatrial node is sort of the heart's normal, natural pacemaker, and will contract at a rate of, on average, in adults, 60 to 100 times a minute. And because it happens to beat the fastest, it commands most of the attention, and the heart will obey its command most of the time under normal circumstances. So the sinoatrial node develops a voltage potential, reaches a threshold potential, depolarizes, and sends a signal through specialized fibers to the atrioventricular node. The AV node is so named because it's situated between the atria and the ventricles. And this is where the signal to beat is sort of processed, collected, and then once it reaches threshold, it too will send a signal down specialized fibers called the Purkinje fibers. The Purkinje fibers are rapidly transmitting fibers that conduct the electrochemical signal along the heart muscle, and this instructs the ventricles to beat. So you can imagine that this would probably give rise to your P wave, right? So the P wave is formed by the atria contracting and then repolarizing. The AV node is where that PR interval is going to occur as the AV node sort of processes the signal that it receives from the SA node. And then the QRS complex is formed by this transmission along the Purkinje fibers, and the powerful muscular walls of the heart contract, and that gives rise to the QRS segment. And then everybody relaxes, and you get your T wave when the heart muscle cell repolarizes. So it looks like SA node correlates with the P wave, QRS, that's the AV node, resulting in your PR interval. And then your QRS complex as the ventricular myocardium contracts and propels blood up to the lungs and throughout the body, and then your T wave. Okay, everybody got that? Clear as mud? So let's move on to EKG interpretation 101. EKG interpretation always starts with rate. So fast or slow? Is it fast or slow, or is it normal? Then we look at rhythm, something called axis, which we'll touch on briefly, various intervals and their importance. Hypertrophy, or how big the heart muscle is, can have implications ranging from serious to not so serious, but we pay attention to that based on how large the voltages are that we're seeing in the QRS complex and the P waves. And then ischemia, which is sort of the belle of the ball. Everybody pays attention to ischemia, sometimes at the expense of other findings. So rate. My question when someone comes to me with an EKG in the ER is the rate fast or slow? If it's normal, then great. There could be other findings and I can move on. But if it's fast, that's interesting to me. If it's slow, that's interesting to me. And of course, kids have different values than adults because adults are just big kids. But in newborn, you'll have a much higher rate than, for instance, a preschooler. You don't need to know those numbers. It won't be on the quiz. You can get a sense for the heart rate on the EKG without looking at the machine interpretation, which, by the way, is often wrong. You can get a sense for the rate based on counting big boxes. So if a QRS occurs once every big box, that's a fast heart rate. That actually equates to about 300 beats a minute. So if you do the math, this is 300 beats a minute. 2 big boxes is 150 beats a minute. 3 big boxes is 100 beats a minute. 4 is 75, 5 is 60. So anywhere between 3 and 5 big boxes per QRS, that's a normal heart rate, normal ventricular heart rate anyway. So this is what we call, and by the way, when I'm looking at an EKG, I generally look at lead 2 in order to determine the rhythm. And I see that in this particular EKG, there happens to be a P wave in front of every QRS, P, QRS, P, QRS, P, QRS. There are no isolated P waves doing their own thing. They are all tied to QRSs on this EKG, at least this rhythm strip that I'm seeing. Furthermore, there is a QRS right after every P. PQRS, PQRS, PQRS. There are no QRS complexes hanging out without an attendant P wave. So I can say, at least based on this strip that I'm seeing, that this is normal sinus rhythm. This is neither fast nor slow, so let's count the boxes. This is 300, 150, 100, 75, 60. So this is between 60 and 75 beats per minute, right? Based on our counting of the big boxes. So this is a normal rate. And I know that because there's a P before every QRS, there's a QRS after every P. I know this is regular sinus rhythm being a normal P QRST formation. So they march out like that. If there are abnormalities, then we become more interested in the lead. So this is normal sinus rhythm. The rhythm is regular as opposed to irregular. The rate is normal, so it's between 60 and 100. The P waves are normal, and if they're abnormal, that tells us something about the patient. The PR is normal, so the PR interval is a normal length, and not short, not long. And the QRS is nice and narrow as opposed to widened. And there's pathology that can tell us that we can tell if the QRS is wide. So rate and rhythm. We want the rhythm to be regular, the rate to be normal, P waves to be upright and not particularly wide, the PR to be normal in duration, and the QRS to be narrow, nice tight QRSs. And that's a normal EKG. Rhythm. So rhythm disturbances are very common. Most rhythm disturbances are relatively benign. Some are dangerous, and some are deadly. This is an irregular cardiac rhythm, which you can tell because there's a beat here, or 2 beats, and then there's a little delay of the beat. The beats and the distance between the beats are variable and irregular. So we call that an irregular rhythm. There are such things as a regularly irregular rhythm, such as if there were two QRS complexes back to back and then a delay, and then 2 QRS complexes back to back and then a delay. That would be a regularly irregular rhythm. But an irregularly irregular cardiac rhythm is characteristic of an entity known as atrial fibrillation. Atrial fibrillation. This is a very common condition, something that you will see quite a bit of when you become a doctor burdened with all sorts of medical school debt. So in AFib, the rhythm is regular. The rate is often fast, doesn't have to be, especially if your rate is controlled with medications. The P wave is absent. The P wave is absent. And the reason for that is because the atria are contracting sort of willy-nilly. Those muscle cells are contracting willy-nilly. The SA node, the sinoatrial node, is no longer the dominant driver of the cardiac rhythm. Instead, all sorts of atrial muscle cells are competing to tell the AV node to send its signal down the ventricles. And so you will have an absent P wave. There's no organized atrial contraction. And the PR is absent because there's no P wave, and the QRS usually be nice and narrow. So this is what AFib sort of looks like. So in normal sinus rhythm, you have the SA node in organized fashion delivering a signal to the AV node, which sends the signal to the ventricles to beat. In AFib, the SA node has abdicated authority. It has stepped down from the throne, and all these other players are getting excited to cause the ventricle to beat. And so the AV node is receiving way too many signals from all over the heart, and it's confused about when to beat and when not to beat. So it will just send signals whenever it feels like it based on when it reaches its action potential threshold. And so it'll be too fast and too often and in an irregular pattern like this. This pattern down here is irregularly irregular. But the QRS complexes, note, are similarly, they have similar morphology. So they look the same, nice and narrow. That's AFib. There's another type of conduction disturbance problem that befalls the unlucky. And we'll talk about this briefly because it's interesting. This is a process where you see this rhythm strip. This happens to be lead 1. You have a P wave, and then your PR interval is very, very short. Look at that PR interval. Normally, a PR interval is about 120 milliseconds or 0.12 seconds. But then you see here this kind of slurring of this R wave here. Normally, an R wave will be very linear, sort of a slanted linear pattern. It usually doesn't curve like this. So what could cause this? It's almost as though after the P wave is generated and the atria contract, it's almost as though the AV node is letting signal go down through the Purkinje fibers to the ventricles too early. The AV node isn't doing its job, stopping the signal, processing the signal, and then sending it down those Purkinje fibers. So this is what's known as WPW, and can degenerate into this type of problem if you're unlucky. So WPW can result in this, what we call a reentrant tachycardia, where there's an abnormal collection of cells that will propagate what we call a circus rhythm or a circuit that's abnormal. And you can tell that this heart rate is fast or slow. This will be on your quiz. That's right. This is a fast rhythm. So what's the rate here? This is one big box. So that's 300 beats a minute, at least for this little run. 300 beats a minute. Do you think the heart is going to have time to dilate, accept blood, and be able to squeeze out an adequate volume of blood to perfuse tissues if it's going that fast? Probably not. So a rate of 300 beats a minute usually is not compatible with life. And this is sort of a perimortem EKG here, unless you fix it. So WPW is fun. There's another type of reentrant tachycardia called SVT, or supraventricular tachycardia. This also is caused by an abnormal electrical circuit that develops in the around the AV node, and this usually isn't deadly. It's just uncomfortable. It can cause a lot of discomfort and sometimes impede blood supply to various organs such as the brain or the heart, and it's a good thing not to have. So if you have it, we can fix it, but its characteristic pattern is displayed here, and what we see is that so it's a regular rhythm. We know that it's fast, right? So it's fast, it's regular. The QRSs are narrow, but where's the P wave? Where's the P wave? In fast rhythms, you always have to hunt for the P wave. This isn't a P wave, this is a T wave, right? So in SVT, the AV node is sort of conducting the signal inside of itself in this abnormal circuit, resulting in rapid delivery of signal to the ventricles, and the ventricles beat too fast. And this is a rate of, who's gonna calculate the rate? So this would be, let's see here. We'll start here as it lines up with a thick line. So this is one big box, that'd be 300, and this would be 175. And that's characteristic of SVT. SVT usually hangs out in the 160 to 180 range. Usually the average is about 170, and it's just pegged right there. And that's characteristic of SVT. So if somebody has a narrow complex tachycardia, comes to me in the ER and says, my chest hurts, and I see up on the on the cardiac monitor that their heart is beating at 170 and doesn't change, like that rate doesn't change for minutes, then I'm pretty sure this is SVT, and that tells me how to fix it. So normal heart will send its signals from the SA node to the AV node and then to the Purkinje fibers, the ventricles. In SVT, the signal may have initiated at the SA node, but it becomes trapped in the AV node here, and I'm going the wrong way. There's a circuit here, you can see in green, and this circuit is constantly sending signals to the ventricles to beat, beep, 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 beep. In WPW, the circuit is a little bit different. It involves ventricular myocytes, not just AV nodal heart cells. And as a result, you get this, this slurring of the R wave and the what we call the delta wave, which we showed you earlier. Let's see here. I think I'm going to skip ahead so we can talk about ischemia, which is everybody's what everybody wants to talk about. Paying no attention to the man behind the curtain. I suppose we can talk about hypertrophy. So the size of these various waves, P wave, QRS, these various morphologies, is determined by how large these structures are. So you can imagine that if you have big, chunky, muscular atria, your P wave will be big. If you have a big, thick left ventricle, you're going to get big, tall QRS complexes, because all of those extra myocytes that have developed to propel blood throughout the body give extra voltage relative to their normal hearts in other people. So ventricular hypertrophy, as demonstrated here, is interesting. And there are various criteria for ventricular hypertrophy, but a quick and dirty way of calculating left ventricular hypertrophy is take the height of QRS complex in V5, add it to V2. If it's greater than, I think it's 35 millimeters, or 7 big boxes, then that constitutes left ventricular hypertrophy, or LVH. And LVH is a sign that your heart has been working against extra pressure for months and years, and you've developed extra left heart muscle, which is pathologic. It means your blood pressure has been high for too long, your heart has bulked up, and you have extra heart muscle there causing this extra large signal. And over years, that can result in strain and badness and set you up for things like heart attacks. The tall QRS and the precordial leads. Atrial hypertrophy is, you can imagine, the atria contracting, resulting in a P wave. If the atria are big, they give you a big P wave, right? So this person has big P waves for whatever reason. If it's larger than, let's see, 2 little boxes, that constitutes P wave hypertrophy. So bigger than 40 milliseconds. And the causes for P wave hypertrophy or atrial hypertrophy are generally caused by problems in the lungs. So someone with, say, bad emphysema, whose lungs are abnormal, you can imagine that the arteries in their lungs are abnormal, right? So they're going to have diseased pulmonary arteries. And because of the back pressure against the right atrium in this case, the right atrium has become big and muscular and is resulting in this extra large P wave here. Left atrial hypertrophy. Oh, by the way, you'll see right atrial hypertrophy primarily in lead 2. Left atrial hypertrophy is caused by problems getting blood out of the left atrium for a variety of reasons, but most commonly because of valve stenosis. You have the mitral valve, which admits blood from the left atrium into the left ventricle. If that's stiff and not admitting blood freely, then the atrium has to work at propelling blood from the atrium to the ventricle, and you'll get a big left atrium. And that is represented by this sort of biphasic P wave. The classic left atrial hypertrophy is greater than 40 milliseconds, and it's a biphasic P wave. So up, down, greater than 40 milliseconds. Ischemia. All right. So ischemia, when we talk about ischemia, what we're talking about is heart is under strain because of inadequate blood supply. And the word ischemia can apply to any organ. Theoretically, your spleen could be ischemic, although that never happens. But brain can be ischemic, right? So ischemia to the heart results in characteristic findings on the EKG that we'll go over. And it implies that the blood supply to that section of heart muscle is reduced. And you see this primarily in the ST segment and the T wave. And you can get a sense for which blood vessels involved based on the pattern that you're seeing on the 12-lead EKG. And what it really represents is the T wave and the ST segment are where the heart's relaxing, right? So this will be a problem with repolarization, or a problem getting the ions that just migrated between sides of the cardiac myocyte membrane back into position. So if your heart doesn't have the energy to do that, for instance, because it doesn't have enough oxygen, then repolarization will be disturbed. And you can tell that on the EKG, and we call that ischemia. And what it has to do really is your cardiac myocytes rely on oxygen to conduct its creation of ATP, right? So ATP isn't being produced, and as a result, you have no energy to transmit these ions back into position, and then you die. So this is the coronary blood flow. Once again, the right main coronary artery gives rise to its various branches. The left main gives rise to the left anterior descending and the left circumflex, which wraps around the back of the heart. And this is what ischemia looks like on the EKG in various forms. But the sort of the bottom line is that true ischemia results in J-point depression, or ST depression, relative to the T-wave, P-wave interval, the TP interval. If you measure it against the PR interval, sometimes you'll be fooled. So the ST segment, when it is depressed, particularly more than 1 millimeter, so 1 millivolt, or one little box, then that should cause your hackles to rise. Your patient is sick, doctor. And what is coronary ischemia? So we've all heard about cholesterol and cholesterol plaques. So what happens is these calcified plaques develop in the coronary arteries, and over time they grow and grow, and most of the time they cause no problems. But if your heartbeat, if this channel through which blood must pass is too narrow, then you can imagine that at some point, say when your heart starts working fast, that muscle that requires more oxygen now that it's working fast won't get enough, and that connotes ischemia. And that's when you start having exertional symptoms like shortness of breath and chest pain when you're on your treadmill. And there are varying degrees of what we call stenosis or narrowing of these arteries. So this is a maybe 60% blockage. This is a maybe 99% blockage. And you can imagine that a 100% blockage would result in a lot of ischemia. And when we get to that point and heart cells start to die because they're literally not getting any oxygen at all, we call that infarction. And that gives rise to the term myocardial infarction, which is an exciting time. So this is what it looks like on an angiogram. So this is where the cardiologist got out of bed at 2 a.m., drove his Mercedes to the hospital and cannulated this person's aorta and drove this cannula up to the, let's say this is the right coronary artery because it looks like the right side of the body. You can tell this is an angiogram. This is a fluoroscopy. This is basically an X-ray. You can see the vertebral bones here. So we're peering basically through the heart, and he's squirted dye. She has squirted dye into the right coronary artery, and the dye is causing this black pattern here, and this is blood flow. So the dye is traveling along the vessels, and whoa, you can see that this area of the coronary artery is really tight and tiny. There's very little blood going through here, and it reconstitutes on the other side, so it's not all the way occluded. But it's at least 99% occluded. So this is a person who came to the ER having a lot of chest pain and had ST segment depression in particular leads. And so the cardiologist knew to go right after that particular artery. And what will happen is she will deploy a stent into this area, open this area up, and result in the patient living a long, happy life. So what's a STEMI? We've all heard about STEMI. STEMI stands for ST elevation MI. What are we doing? Good. ST elevation MI, or ST elevation myocardial infarction. This pertains to new ST elevation at the J point, not old ST elevation. And some people do have residual ST elevation after a heart attack, or maybe they've had some other heart problem and they have this abnormal morphology on their EKG, and that's just normal for them. But any new ST elevation of the J point, particularly if your patient is having symptoms such as chest pain or shortness of breath, or they just passed out and won't wake up and don't have pulses and they're looking gray, do something, doctor. That's a STEMI. It has to involve two contiguous leads, and the ST elevation has to be greater than 0.1 millivolt or 1 millimeter. And particularly, we look at the V leads, so the precordial leads, V2 and V3. It's different in men than in women, and age 40 and over 40, and blah, blah, blah. You don't need to worry about that. And if you have what we call reciprocal ST depression, meaning that on the opposite side of the heart, instead of being elevated, the ST segments are depressed, that helps you confirm the diagnosis. And the reasons for that are beyond the scope of this topic now that it's 1 minute past our ending time. This is what an ST elevation MI looks like in various stages of evolution on your EKG. So here is where you start playing golf and you're asymptomatic and enjoying your day. And then all of a sudden you start having symptoms, whether it's shortness of breath or profound fatigue, or you just start sweating, or maybe you have chest pain. Your ST will start to rise. And then your ST rises in sort of different shapes, which are very ominous. And then eventually your ST segment comes back to normal after your heart muscle has died a little bit. You have these residual T-wave inversions, and then you go back to normal. But what's this? What's this that we see here? It wasn't quite as big here. What happens here is that our Q wave has become enlarged. So this patient, what this means is that there's not enough heart muscle left to depolarize to create the tall R wave that this heart was used to. Some of this ventricular muscle has died. And in dying, it produces this Q wave because heart muscle is depolarizing sort of in the areas of the heart where it used to, producing this pattern. It's also propelled sort of backwards relative to this, this lead that we're looking at, more so than it had been. So the relative difference in voltage potential is reflected by an increase in the Q wave and a decrease in the R wave. So this patient is Q'd out, and they have some dead muscle cell there. And we determine the coronary artery involved in the STEMI on the EKG based on where it's located on the 12 lead. And this schematic sort of gives you an idea of what leads are involved with what blood supply. So here's your left anterior descending artery. Here's your circumflex. This is all the left side. Here's your right coronary artery, your inferior wall. And on the 12 lead, this is what it looks like. So lead 1 and AVL are called our high lateral leads, and this is part of the left circumflex or branches of the LAD. The LAD will give you ST changes in the what we call the anterior leads, or the V leads right over the sternum. These are your lateral leads, V5 and V6. And then your inferior leads, 1, 2, and AVF are your inferior leads. So I can tell, having looked at 3 or 4 EKGs in my life, that this person is having problems with a particular heart artery based on the fact that I know that leads 2, 3, and F are, first of all, there's ST elevation here, right? In these leads. So this is the right coronary artery distribution. So I'm worried about a right-sided heart attack. I'm going to confirm that diagnosis by looking over to the reciprocal leads, so the anterior leads, and I see ST depression here. So this is an emergency. And give this patient some aspirin. Go to the cath lab. And here's another example of an ST elevation MI. In this case, it's not the inferior leads. There's no ST elevation here. You could argue that there's just a skosh of ST depression in lead 3 here. But there's ST elevation in lead V2, V3, V4, all the way to V5. So guess which artery this is? This is the left anterior descending artery. This is the LAD, and these are tombstones. This is the widowmaker, as they say. This is a big anterior MI. Bad news. So here's another inferior MI, ST elevation in the inferior leads. This one has a little bit of reciprocal depression in AVL, so this is probably the little bit of reciprocal depression in the lateral part of the heart. And I think that's it, folks. We just had a heart attack. Let's see here. Is anybody still with us?
Oh, yeah.
Oh, boy. That's exciting. All right. Thank you. If you have any questions, bug Ariel. I can't hear anybody. Bye.